谢谢刘医生的邀请，很高兴今天来到这里跟大家分享一下这个医疗缝制的问题。刘医生说今天是我们是一个国际的一个项目，所以他要求我们用英语发言，我只好用英语发言。不过我的 PPT 都是双语的，中英文都有。今天我跟大家分享的题目就是资源配置跟医疗系统的效果。So today I'm delighted to be here to share some of my views on healthcare financing and its impact on quality, on efficiency. This is an area that I've been researching on for many years, so I'm glad to share some of my insights on the arrangement. I would particularly focus on comparison between Hong Kong and the Chinese mainland in terms of healthcare financing arrangement. So regardless of how you design your healthcare system, I think there are three things that we need to be clear. So we try to do our best to produce highest quality of care to our population. We try to provide it to everyone. So the second factor is equity. And the third factor is cost, at a reasonable cost. It is of course very easy to say that we want to do all these three things. But these three things are actually kind of mutually exclusive. If you do good in one, you cannot probably do so good in the other two factors. So that is what healthcare financing design is all about. How do we balance the three to achieve the desirable outcome? And if we talk about financing, first of all, we need to look at, do we have enough money? Where does the money comes from? The sources of funds. So we look at the different sources of funds, and then we see how we should get the money, who should pay for what type of services, and how should we arrange payment so that that would achieve the best results. And if we look at the sources, so there are so many different ways we can collect money for healthcare. So these are the possible methods that we use to collect money for healthcare. So you have taxes, you can have social insurance like in China, you can ask users to pay. In Singapore, they have medical savings account. In China also there's a 个人账户, which is some kind of a savings account. And private insurance plus donations by charity, by international bodies. And then the other side is, of course, your total healthcare expenditure. So you try to use all of these sources to come up with a sum which can adequately deliver the healthcare to your population. Now the second thing, after you have the money, you have to decide how do you pay the providers to achieve the best possible outcomes. So we're talking about payment mechanisms. So there are different ways to pay, and one way, which is the Hong Kong way, the easiest way, is to give a block grant to the hospital authority. Give them a big sum of money and let the authority decide how to do it. And another way is to pay by so-called capitation. It depends on how many persons you have. Or you can also pay, which is very common, so-called fee for service. You pay according to the service people receive. Or case mix, you pay according to a particular disease, a particular condition. And now getting more popular is a thing called pay for performance. We look at outcomes, we look at output, and we try to pay according to the desirable results. And of course, fixed salary is another way. So there are two major healthcare financing systems in this world. There is the so-called Beveridge model, or the British model, And the other model is the German model, or the social insurance model. So Hong Kong basically follows the British model, and in the mainland it's basically the German model. And under the British model that we are familiar with, a lump sum is given to authority. The authority gives money to public hospitals, and citizens going to hospitals do not need to pay much. So that is the British model. Very simple, easy, and people like it because of its simplicity. And people think that as long as I'm a citizen, I pay tax, I don't have to pay any other contributions. The German model, which was practiced in Germany, in many European countries, in Canada, and in Asia, in China, in Taiwan, South Korea, they also practice that. So basically, this is a social insurance system whereby the government would deduct your salary every month and then put into a social insurance fund. Normally, 3 parties would contribute to that fund: the employee, the employer, and government. And then if you are sick, then of course this fund would pay for your healthcare expenses. The good thing about this is that you can choose your own providers. You don't have to go to public hospitals. You can go to private hospitals, public hospitals of your own choice. Now this is how Hong Kong finance our healthcare. So you can see that taxes constitute about 50%, mostly covering hospital care. Out-of-pocket payments is about 35%, which is actually quite high by international standards. And insurance would cover the rest, 15%. Half of that are individual insurance, and half of that are employer-sponsored insurance. So it's actually 50, 35, and 15. This is sort of the mix of the Hong Kong healthcare financing pie. In the mainland, the mix is actually not so different. You can see out-of-pocket payment is also about 1/3, and insurance, social insurance plus taxation is 2/3. So it's sort of similar to the Hong Kong arrangement, but of course you have a much bigger social insurance contribution. Now, which is better? So the tax-based system or the social insurance system is better? And which is more sustainable? Now that's difficult, but if we're talking about aging population, neither systems are sustainable. Both taxation and social insurance would not be sustainable because you have fewer people paying taxes, fewer people paying insurance premium, and more people, more retired people needing more health care. So neither systems are sustainable. So if you look at the situation, if the population is young, so no problem, these people are paying taxes to support these people. But if you have so many retirees here not paying taxes but receiving benefits, you have fewer people paying, then you have a sustainable problem. So what to do? Now the only possible way is to improve efficiency, do more with less. So that is the only way forward. So how do you do more with less? And we economists think that there are 2 types of efficiency. One is so-called allocative efficiency, whereby you allocate more resources to areas that produce best results. The other type of efficiency is technical efficiency, whereby after I give you the money, you spend it in the most efficient manner. So how do we do that? So in terms of allocative efficiency, it's actually so simple. You allocate more resources to primary health care, to prevention, to early detection. So you treat patients in the more effective manner. But in order to do that, you really need to centralize the resources. Otherwise, each hospitals would ask for more, primary care ask for more, long-term care ask for more. So if you put all the resources under one roof, then that authority can more effectively divert and redeploy resources. So if you look at Hong Kong, this is the situation. All our money goes to public hospitals. Very little goes to primary care, very little goes to long-term care, and even less goes to community long-term care. So all these people wind up in public hospitals, which is not effective and so expensive. $7,000 per day if you stay in a public hospital. Now, most countries would complain that they don't spend enough on primary health care. But Hong Kong is particularly bad when compared to other countries. If you look at the spending, most countries would spend over 30% public money on primary health care. Hong Kong spends 17%. So only half of what most other countries in the world spend. And most people in Hong Kong, we have to use our own pocket, out-of-pocket money to pay for primary health care. And the rest of the world, we don't need so much out-of-pocket. In the mainland, it's also below its national average, but still better than Hong Kong. And what about payment systems? After we get the money, so how do we pay our providers to achieve the best possible outcomes? Now in Hong Kong, we give one big sum of money to hospital authority. And the hospital authority then gives lump sum to public hospitals. And patients, when they go to public hospitals, don't have to pay. And doctors receive only fixed salary. So no incentive for them to really work hard to get more patients. So that is the picture. 90 billion to buy the year gives the hospital authority. Hospital authority dish out to hospitals and patients get good care. Now the problem is this, is we have a thing called perverse incentive. We reward bad service. We penalize good service under this arrangement. If you do a good job, you attract more patients, but you have no extra resources. If you do a bad job, no one comes to you, you keep all the resources. So that is the problem with this block grant system. So look at the Hong Kong waiting time for joint replacement. And I always like to show this chart. So these are the median waiting time in months, okay? Not in days, in months. So I've never seen anywhere in this world where people can wait 95 months for a hip replacement. 95 months. Most people probably die before they get their turn. And this is the median waiting time for OECD countries. So in terms of months, it's like 3 months, 1 month, 2 months. And we're waiting 95 months. So what is the problem? I think the main problem is no incentive for them to work. So the thing to increase efficiency would be not to give any money to hospitals to begin with, gives the money to a purchaser, and then when patients go to hospital, this purchaser pays for the patients. That way, the more you do, the more resources you get versus the existing system. What about in the mainland? In the mainland, they have two types of insurance. The employee insurance, which is basically a social insurance based on employment. And the second type is the resident insurance. So if you're not employed, then you're covered under you can participate in the resident medical insurance. And under the mainland system, money follows patients, okay? So individuals, taxation, and employers contribute to the social insurance, and then patients also pay some out of pocket. But the more patients you treat, the more resources the hospital gets. So there is less incentive not to do work in mainland hospitals. So I cannot find any comparable data on hip replacement in the mainland, but just because it is money follows patients, so I have reason to believe that they are more efficient in treating patients. So there is a report recently that I've read, and they talk about improving the hospitalization waiting time from 10 days to 3 days. So 10 days to 3 days. So in Hong Kong, but this is of course include all the urgent cases. The average is 3 days. So even the longest waiting time cannot be too long. And fee-for-service is the predominant way of reimbursing hospitals. Now that can also be another problem, which is overutilization. You treat more than what is necessary. So I think what they're doing now is they're reforming the fee-for-service systems to include this thing called global budgets. So each hospital is given a global budget. You are being reimbursed based on fee-for-service, but you must not exceed the global budget. If you exceed the global budget, you don't get extra money. So that's the way to control costs, but at the same time also try to incentivize hospitals to do more. And what about primary care? Now primary care in Hong Kong, mostly delivered by private doctors. Private doctors always charge on a fee-for-service basis, so no incentive for them to deliver preventive care. Because preventive care, how much can you charge? Talking to patients, counseling patients. So they are not being delivered by private doctors. And public doctors are based on fixed salary. So recently, government has started some initiatives which is in the right direction. This chronic CCDC, chronic disease co-care scheme. And this is something which the government tries to incentivize private doctors to provide preventive care. So every patient that goes to see a doctor, the government will subsidize 2/3 the amount for the consultation. All the tests are free, paid for by government. And so there is some incentive for family doctors to deliver primary health care. And initially there are 2 programs, one for hypertension and one for diabetes. And more will probably be rolled out. And also, there is a subsidy for drugs provided to the primary care doctors. And what is more interesting is there is a pay-for-performance component. So if your patient's condition improves, then there is a bonus to the doctor. So I think that is some good arrangement that Hong Kong is now practicing. And in China, they have a thing called public health service package, whereby some providers are given a budget based on capitation, number of population in that area. And then the staff there would be compensated based on fixed salary and also some performance-based bonus. So that is how they try to incentivize public preventive care delivery in China. Now, long-term care is another big area, which requires a lot of work. Now, in Hong Kong, there are 3 schemes. First scheme is that government subsidizes some NGOs to deliver the care. And that is not enough, so government now also contracts also for 5 places from some private providers, and also provide some vouchers for home care. But if you look at the situation, those that are government subsidized homes, which are slightly better quality, are actually delivered only about 1/3 of the beds in Hong Kong. The rest are private. These private beds are generally poor quality in terms of care. And the way is that tax is given to the Labor and Welfare Bureau, and they give more money to the subsidized home, less money to the fourth place home, and zero to private homes. And then the consumer needs to pay full cost to go to private homes, which are of poorer quality. And there's also too much emphasis on residential care and not enough on community and home care. Waiting time for home care is very long. And there are over 10,000 people waiting for home care and community care. So waiting time is 13 months. And in China, they are instituting long-term care insurance. So there are some pilot cities which have long-term care insurance. In many Asian countries, they are already doing it. So, Japan started that 20 years ago, Taiwan has it, Korea has it. So there are now 29 pilot cities, and in the Greater Bay Area, Guangzhou is one of the pilot cities for long-term care insurance. Basically, this is sort of an extension of the health insurance, but with a separate long-term care fund. And since implementation, some studies have done to look at the impact, and it shows that with the implementation of long-term care insurance, outpatient expenses decreased by almost 25%, and then inpatient claims decreased by almost 20%. So that is really very significant improvement. And also one study shows that mortality rate in those countries also decreased with long-term care insurance, and the ADL scores also declined much less, 10 times less than without. So I think that shows the importance of long-term care insurance. So in summary, both tax and social insurance itself would not be sustainable because of aging population. Block grant, fixed salary, fee-for-service payments are also problematic. So they're not likely to improve efficiency. So what we really need to do is to try very hard to improve allocated efficiency and technical efficiency if our healthcare system is to be sustainable. So we should put all the money under one roof and let this authority shift resources around and not in separate silos. So we really need to improve technical efficiency by doing away with block grants, by also modifying fee-for-service systems, and also we need to develop our primary and long-term care financing systems. So that's all I have. Thank you.